first we're going to talk about normal liver, so we can understand pathology later. A pathologist likes to see the liver is broken up into different areas. This is a gross section through the liver, and we like to see the portal area and the central vein and all the hepatocytes in between. We kind of call the lobule. And I'll show you how this lobule tends to be broken down into several zones, and based on the inflammation in those zones, we can kind of get an idea of what the etiology of a patient's liver injury is. Okay? This is a microscopic section. If you took a little section right there and put it on a slide and stained it, this is what it would look like. This is the basic hepatic lobule. We've got the central vein in the center of the lobule, and surrounding it are all the portal tracts. Okay, and then you've got the hepatocytes, the small pink cells, extending up to the central vein here. Okay, now blood flow is going to enter the liver through the hepatic artery and the portal artery and the portal vein. And it's going to flow through the sinusoids into the central vein and out the hepatic venous system. Okay, bile, on the other hand, flows the opposite direction. Bile is going to flow from the zone 1 areas down into the portal tracts, into the larger bile ducts, and then eventually out through the large bile ducts. Okay, in the hilum. Here's how we break the liver into zones. You've got the portal tract here. There's the portal vein, the bile duct. The arterial is not well represented here, but I'll show you that in another picture. There's the central vein. Blood flow, remember, is going to go from here to here. And then here's how we separate the liver into zones. Zone 1 is the hepatocytes right around the portal tract. We call that the periportal zone. Zone 2 is midzonal because it's in the middle. Zone 3 is pericentral, and these are the hepatocytes right around the central vein. There's no hard line between these zones. It's essentially a pathologist's gestalt as to whether he thinks the inflammation or the inflammatory process is closest to the portal tract. We'll call that zone 1. If we think it's closest to the central vein, we'll call that zone 3. If we think it's kind of in the middle, we call that zone 2. Okay. These are the diseases that affect each zone. Okay, chronic viral hepatitis, chronic hepatitis B and C is usually portal inflammation in zone 1. Autoimmune hepatitis, also zone 1 portal inflammation. Primary biliary cirrhosis and primary sclerosing cholangitis, also zone 1 diseases. Lobular or zone 2-3 diseases are going to be your steatohepatitis, whether it's non-alcoholic, so NASH is non-alcoholic steatohepatitis, ASH, alcoholic steatohepatitis. Drug injury tends to affect zone 3 or zone 2. It can also be portal, so I like to, realistically, drugs could be in either category, but for simplicity's sake today, we'll keep it here because this is the usual pattern. And ischemia usually affects zone 3 also. Okay, so keep that in mind. The zone where the inflammation is or where the injury is tells us what the possible etiology might be. Okay. This is a high-power image of what a normal portal tract will look like. Every portal tract has its portal vein, its hepatic artery, and its bile duct. The veins usually a bit larger. The arteries are going to be about the size as their paired bile ducts. Okay. Also, the arteries have thicker walls, so if you're looking at a section, you can tell which one's the artery and which one's the larger vein. Notice most portal tracts have very little inflammation. You may find 1 or 2 lymphocytes or plasma cells normally in a portal tract, but really you should just see pink connective tissue. You shouldn't see many of those blue cells, those blue chronic inflammatory cells in the portal tract. Other cells of the liver, the Kupffer cells, these are part of the reticuloendothelial system. They're essentially the phagocytic cells of the liver. They tend to sit in the sinusoids. Often we can't see these. We really start to see these when there's been liver injury, and these cells become hyperplastic and proliferate because they're trying to chew up all the debris in the liver from the injury. Acidophil bodies, I have this under the normal component, but acidophil bodies really are never normal. These are single dead or dying hepatocytes. Okay, so if I see maybe 1 acidophil body in a liver biopsy, I'll probably ignore it. If I see any more than 1, I'll probably mention it. Acidophil bodies are dying hepatocytes, and those are never, sorry, there it is right there. Those are never considered normal. And really what it is, it's a hepatocyte where the nucleus becomes very dark, because it's becoming pycnotic, right? The cell is dying, so you're getting pycnosis. Eventually you could see this break up, that's karyorrhexis, and eventually the cell's just going to disappear. Okay, so acidophil body, single dying hepatocyte. Just to reiterate, these are the diseases that affect the liver, and these are the zones that they primarily affect. Okay, so remember, zone 1, we're thinking chronic viral hepatitis, Hep B or Hep C, autoimmune, PBC, PSC, large duct obstruction from a stone or a tumor is also zone 1. Everything starred here is commonly zone 1, but if it's got a star on it, it can also be zone 2 or 3, the lobular patterns. So drugs, autoimmune hepatitis, Wilson's disease, these can show both patterns, okay, making them more difficult for a pathologist sometimes to diagnose. Okay, your typical, usually isolated zone 2, zone 3 hepatitis are going to be your acute viral hepatitis, not your chronic. So this would be acute Hep A, acute Hep E, acute Hep B, or acute Hep C. Chronic, remember zone 1, but acute can be zone 2 or 3. All your steatohepatitis, whether it's alcohol or NASH, is going to be zone 2 and 3. Ischemic injury is zone 3, and remember drugs and these others can do both. Okay? Shout out questions if you have them as we go, please. For our discussion, and because most of you won't be liver pathologists, we're just going to focus on these diseases, okay, for the purpose of this talk. So before we get, we're going to do it based on cases and patient presentations. I think that's a bit more fun than just showing slides. But before we do that, here's some examples of what I mean by portal-based inflammation. So this would be your zone 1 pattern. You've got a portal tract here. It's very blue. It's very blue because it's full of lymphocytes, probably a few plasma cells. So that's your typical chronic hepatitis zone 1 or portal-based pattern. There's your comparison to a normal portal tract. Notice how much bluer that is. Those are tons of lymphocytes and plasma cells in the portal tract. This is your example of a lobular-based process. The portal tract is here. And look how it looks pretty clean, not inflamed. Okay, but then you look at the hepatocytes extending between zones 1, 2, and 3, and they all seem to be it's a bit hard on this power, but it's very busy. You do see a lot of inflammatory cells in the parenchyma, but the portal tract looks okay. So this is your lobular or zone 2-3 pattern. Okay, and there's your comparison to normal right there. But you shouldn't be seeing any busyness in that lobule. Right? No neutrophils, no lymphocytes, no plasma cells, no macrophages. Interface inflammation is a term we need to know. Have you guys heard that term before? No? Piecemeal necrosis, have you heard that term? They're synonymous. They used to use piecemeal necrosis, 15 years ago. Now we tend to call it interface hepatitis. But really what that means is you have a portal-based pattern like this, okay? And now all these inflammatory cells, instead of being confined to the portal tract or being just at the limiting plate, are going to go past the limiting plate, right? So that's the area where the portal tract interfaces with the zone 1 hepatocytes, and they're going to cause damage to those zone 1 hepatocytes. That's interface inflammation, okay? So for example, I can draw a line here where the limiting plate is, and I don't expect you guys to see this. This is sort of subtle stuff. This is mainly a pictorial representation. You can draw a line where the limiting plate probably is. You can see all this inflammation has extended past that plate and killed off these hepatocytes. So something like this would be a portal-based zone 1 process with severe interface activity, severe interface damage. Lots of dead and dying hepatocytes right at that interface between the portal tract and the liver. Okay? This is important because when we see a case of chronic hepatitis, meaning a portal-based zone 1 chronic inflammatory process, we're usually thinking viral hepatitis, primary biliary cirrhosis, some type of duct obstruction, something like that. Okay? These never show up with mild interface. These never show up with severe interface inflammation. These always only have mild interface like this. If we see this, we see a chronic pattern like this, but with this much interface damage, we're really thinking autoimmune or possibly drugged. That's the primary differential with the severe chronic hepatitis and severe interface damage. Okay? Chronic pattern with mild interface, you're going to think these processes. So we use interface as a way to help us differentiate various disease processes. Okay? Looking at enzyme pattern elevation, and Joe talked about this, so I won't dwell on it. Even as pathologists, when I'm looking at a liver biopsy, before I ever send out a case, I go into the clinical record and just look at the enzyme pattern to make sure what I'm thinking based on the tissue appearance actually matches what the clinicians are thinking also. Okay? The hepatitic pattern or the liver injury pattern, you're going to expect to see an ALT or an AST elevated out of proportion to the alkaline phosphatase or the GGT. Right? This is a marker of bile duct damage. ALT, AST tend to be markers of hepatocellular damage, so we call this a hepatitic pattern if the ratio is greater than 5. Okay? You see an AST, ALT over 5 times the upper limit of normal, we tend to think of viral hepatitis, drugs, or alcohol. If it's severely elevated, We're thinking more of an acute viral hepatitis, okay? Drugs, toxin, autoimmune, ischemia. So those are all hepatitic patterns that affect the hepatocytes preferentially, not the bile ducts. The opposite would be your cholestatic pattern. This is going to be when your alk phos is going to be elevated out of proportion to your AST-ALT, and that usually means that there's a problem with the bile ducts. Okay, this could be a blocked duct, this could be a primary disease like primary biliary cirrhosis, but usually when we see this pattern, we're thinking that the main issue is going to be with the bile ducts. One caveat is that infiltrating disease of the liver can also cause a preferential alk phos elevation over the AST and ALT, and by infiltrating disease, I mean things like sarcoid lymphoma, amyloidosis, tuberculosis, and even metastases. Okay, so an alk phos elevation over the AST and ALT doesn't always mean biliary disease. It can mean infiltrating disease. And also a bit of a zebra, venous outflow obstruction, such as in like a Budd-Chiari syndrome, where you've got a blockage of the large hepatic vein that drains the liver. If that's blocked, you can get a cholestatic pattern. So keep those exceptions in mind. Okay. Other ancillary tests we use to diagnose liver disease, and these are easy test fodder. Antibodies, it's an easy thing to test on, so these are definitely worth knowing. But for autoimmune hepatitis, we look for the anti-nuclear antibody, anti-smooth muscle antibody, anti-LKM antibody, and elevations in the IgG. Anti-mitochondrial antibody is pretty good. It's pretty sensitive and specific for primary biliary cirrhosis. The ANA is good, not great for autoimmune. A lot of people have an elevated ANA for other reasons, so the specificity is sometimes an issue, and even the sensitivity can be a bit of an issue, but the AMA is pretty good for PBC. Okay, and then we do serologies to look for Hep B and Hep C. Radiologies, if you're worried about biliary disease, you can do an ERCP or an MRCP. You look for stones, tumors blocking the duct. ERCP is good for primary sclerosing cholangitis because you see that typical beaded pattern of stricturing of the large duct. Those diseases are actually usually diagnosed by a radiologist and not by a pathologist, because when we biopsy the ducts, we usually see the small ones and we're not able to see the big ones. And most of these diseases are going to be affecting the larger ducts. Okay? And then other ancillary tests Joe talked about, ceruloplasmin for Wilson's disease, urine copper, things like that. In kids, we look at alpha-1 antitrypsin levels for kids presenting with acute hepatitis, because they can have alpha-1 antitrypsin deficiency, and then iron indices to help in older patients with chronic liver injury for hemochromatosis. So these are all the ancillary tests we try to use. Okay, that's my son Parker on the Pecos River with a brown trout. It's hard to see it. He's covering it. I got to teach him how to hold a fish. So let's do this as a case-based format. We'll sort of go through some of these patients. You guys think about your differential diagnosis, and I'll go over how the histology can sort of help us nail down a more definitive diagnosis. So this first patient was a 45-year-old woman, elevated LFT. She was asymptomatic. Here's her pattern of elevation. Okay, AST, ALT are high, alk phos and GGT normal. So this is a hepatitic or cholestatic. Hepatitic, right? It looks like liver injury. Okay. Here's her history. No family history of liver disease, and she had coronary artery disease and diabetes, but looks like she didn't report a lot of drug, medication use, though she is using IV drugs and alcohol. Okay, so it's a hepatitic pattern, and so our differential at this point with her history is probably going to be a viral hepatitis. So IV drug use puts you at risk for Hep C, multiple sexual partners. Right? She did have the alcohol use. She's also diabetic. Diabetics tend to have the metabolic syndrome, which puts you at risk for NASH. She mentioned. So we have a lot of reasons she could have liver injury based on her history, or even autoimmune hepatitis. Okay. Here's her liver biopsy. Okay. Can you guys tell in this which ones are the portal tracts? At low power, it's hard. It's hard at low power. There's a bile duct there. So you got a portal tract here, a portal tract here, and a portal tract there. Okay, so what pattern is this? What color are these portal tracts? They're blue. So this is the blue portal tract pattern. That's your typical zone 1 portal-based chronic hepatitis pattern. Okay, blue portal tracts. And that's what they look like at low power. If you look a bit closer, What I usually like to do is once I see the blue portal tract pattern, I think, okay, well, this is a chronic hepatitis. I'm thinking Hep B, Hep C, autoimmune, primary biliary cirrhosis, maybe large duct obstruction, something like that. In the back of my mind, I'm remembering drugs and Wilson's and all these things can do this too, but I'm going to shove those into the back for now. Okay? So if that's our main differential, we've got that blue pattern. One thing I like to first do to differentiate between someone goes and say, well, what's the interface look like? If it's severe interface, I'm going to say, well, it's not Hep B, it's not Hep C, it's got to be something like autoimmune. Okay? And what do you guys think of this? You think the interface is mildly inflamed, severely inflamed? Who votes mild? Who votes severe? So if you can, it's a bit of a trick question since you haven't seen this stuff before. If you can really define the edge of the inflammation at medium to low power, it's a mild interface process. If it looks real blurry and you're having a hard time defining the edge, it's a severe interface process. That blurriness would be because all the lymphocytes and plasma cells have gotten out here and damaged so many liver cells, it starts to look blurry and necrotic. So this nice defined edge tells you it's a pretty mild interface process. Okay, so you've got a chronic hepatitis probe-based process with mild interface. So we're going to eliminate autoimmune. Okay. Another example of that mild interface where you can really see that edge, and you see a few lymphocytes sneaking out into the periportal hepatocytes, but really it's pretty mild. Okay. Trichrome stain, which we use to highlight the amount of scarring or fibrosis in the liver, shows that we have some portal-based scarring. The portal tracts are expanded by fibrosis. Okay, so that's compatible with the inflammatory process. We saw a chronic portal-based inflammatory process that's causing portal scarring. Okay, so there's a bit of portal expansion. Okay, so this is a summary of the findings we just talked about. So our differential right now is mainly going to be a chronic Hep B or a chronic Hep C. Still could be drug, but we've really ruled out autoimmune because we don't see the severe interface activity. We know it's not NASH or alcohol because remember those were zone 1 and zone 2 processes. Okay, so this is our main differential at this point. What can we do to sort that out? Usually this is already done by the time the pathologist has a liver biopsy, and I just have to go into the record and check the result. But can you guys think of what, say, a blood test we could do? Serology, right? Just Hep C serology. Okay, and that's what was done. Usually the clinicians are going to do both. They're going to look for Hep B and Hep C. Pathologically, Hep B and Hep C can look nearly identical, so we do like when both are done. This patient had a positive Hep C antibody, so this is a case of hepatitis C. Okay, so your classic portal-based, minimal interface inflammatory pattern. That's sort of your baseline for what chronic hepatitis looks like. Typical Hep C. Okay. Diagnosis is mainly made with serologies. Oftentimes, a patient who presented like this, if they found the Hep C antibody, I imagine in most cases you don't even need a liver biopsy to diagnose that. Though we do like, as pathologists, if we get one, we do like to make sure that the tissue findings are compatible with the clinical findings as well. Keep in mind that the inflammatory patterns for Hep B and Hep C essentially look identical. Most liver biopsies I can look at that are chronic viral hepatitis, I can't tell you whether it's Hep B or Hep C. The exception is sometimes in Hep B cases, in chronic Hep B, you'll see ground glass hepatocytes that look like this. And these we only see in Hep B. We don't see those in Hep C. And you're only going to see those in chronic Hep B. The books say that you see these 50% of the time in Hep B patients. I think I probably see it in 5%. I don't think it's as common as what's written about. Okay? So for all intents and purposes, just think Hep B looks like Hep C to a pathologist. Okay, the liver injury is essentially the same. Okay? Case 2. We're going a little bit quickly, so stop me if you need to ask questions or anything like that. Okay, this is a 50-year-old woman. She had an alk-phos and GGT elevation, and her AST and ALT were only mildly elevated. Okay, so what pattern is that? Yeah, cholestatic pattern. Good. Which fits with her presentation of jaundice and itching. She was using contraceptives, but otherwise no drugs or alcohol. Looked like she didn't have a real risky ancillary history. She was obese, so she did have features of the metabolic syndrome. So that's something to consider too. But based on her enzyme elevations, if this is your differential, which ones do you guys think you should favor? based on the cholestatic pattern. How about the diseases with biliary in it, right? Or it's a cholestatic pattern, right? So let's favor some of these biliary diseases, I think. Okay? Here's your biopsy. Who thinks this is Hep C? Looks like Hep C, right? No. It's blue portal tracts. Doesn't this look similar to the last case? I think it does. I think it looks identical to the last case of this powder. So it's a blue portal tract pattern, okay? A little higher power image of that blue portal tract. Lots of lymphocytes, plasma cells, primarily in the portal tract. Mild interface activity because that edge is clearly defined. So what disease have we eliminated? Yeah, good. It's engaging. This could be liver pathology. So it's not autoimmune. So we're thinking Hep B, Hep C, remember PBC, PSC, those are in the blue portal tract pattern. The cholestatic liver enzymes might make us think, well, at this point maybe we should favor one of those cholestatic biliary diseases, not Hep B or Hep C. But at this power, if I showed this to 10 pathologists, I think most would say, this is Hep C. Okay, so let's go a little closer and take a look. Again, that's our differential. And you're right, we excluded autoimmune. Good job. Okay. Some advanced histologic features. Viral hepatitis, we haven't really talked about the bile ducts yet. We're going to go look at those bile ducts now on the next image. But keep in mind, viral hepatitis is going to be a portal tract pattern, minimal interface activity, and also minimal to no bile duct damage. Okay, PBC is that chronic portal tract pattern with lymphocytes and histiocytes infiltrating into the bile ducts and actually destroying the ducts. So this is the big differentiator from a portal-based pattern that's viral hepatitis versus PBC. It's that bile duct destruction from the lymphocytes and usually some histiocytes or tissue macrophages. Okay, large duct obstruction. If we see something like this that you might see with a tumor, a stone, or in primary sclerosing cholangitis, we usually see onion skinning fibrosis around the bile duct. So these are some things we can look for now to help differentiate this differential diagnosis. Okay. So there's that medium power image. There's the bile duct right there. That was kind of hard to see. Here's a higher power image, and look at that duct. Okay, you've got that duct running right into this mass of small blue cells, lymphocytes, and sort of gray foamy cells, histiocytes, that are destroying the duct. So I call this lymphohistiocytic duct destruction. This is also what's called in a lot of the books as a florid duct lesion. Okay, and this is the lesion we like to see for a patient with primary biliary cirrhosis. Okay, you will not see this degree of duct damage in a patient with hepatitis B or hepatitis C. So we have a chronic portal-based pattern with lymphohistiocytic bile duct destruction, aka florid duct lesion. You see any of those words on a test, you're going to say PBC, primary biliary cirrhosis. Okay, that's your comparison to the normal portal tract. Also, within the lobule, there was a bit of lobular damage. We had an acidophil body here. We had a granuloma there. In the second portal tract in this tissue, we had another small granuloma causing damage to this bile duct. Sometimes, so in PBC, you'll often see written, you'll see it's written that you get a lot of granulomas. Typically we see the lymphohistiocytic duct destruction without the well-defined granulomas, but sometimes we're lucky enough to see a nice granuloma next to the duct. And that really makes the pathologist feel good about his diagnosis of PBC. Okay, so keep in mind that granulomatous duct destruction is also a feature of PBC, though it's really not seen that often. Okay, so a summary of the findings. So, as a pathologist, what I'll do is I'll give sort of a descriptive diagnosis. I'll probably sign this case out as liver with portal inflammation and lymphohistiocytic destruction of bile ducts, C comment. And in my comment, I'll say it's consistent with PBC, but I want one more piece of information. Okay, and what's that? We mentioned it earlier. Serologic test? Yeah, right, the antimitochondrial antibody. I do like to see if that's positive. Okay, so this patient had all this ancillary testing done, and she had a positive AMA. Okay, that's a pretty good serologic test. So with the histology being compatible, the presentation certainly was with jaundice and itching, and then you've got your serologic test that nails down the diagnosis. You put it all together and you get a diagnosis of PBC for that patient. Okay. Next case, any questions on that? Pretty straightforward. That's good. 40-year-old man with right upper quadrant pain. This guy has a really severe AST/ALT elevation. Okay, alkaphos, he's got quite the history also, IV drug use, polysubstance abuse, alcohol. He says he has had the same partner for 3 years. He's getting a little jaundiced. Okay, no history of liver disease. So essentially an acute presentation with a hepatitic pattern. Okay? So clinically, we probably think some type of drug, right? Alcohol, maybe. Maybe acute viral. This is a bit uncommon to present like this, but I guess we'll keep it in differential, or even autoimmune. Okay? So here's an example of his liver biopsy. This one's a bit, I would focus on, this is the trichrome stain, but just look at the portal tracts. You know, in this case, they're really not inflamed. We're not seeing that blue portal tract pattern, okay? So looking at the tissue right away, even at this power, you can say this is not the chronic portal-based pattern. So we've eliminated chronic Hep C, chronic Hep B. We've probably eliminated autoimmune because you usually see at least some portal inflammation in autoimmune. So we're going to think about probably more of the acute hepatitis. Okay, higher power look at that portal tract. Remember what the other ones look like? This really doesn't have that blue appearance. We don't have a lot of lymphocytes and plasma cells. Okay. The lobule, on the other hand, so this would be probably zones 2 and 3. This is medium power, this is high power, this is your normal comparison. Look how busy the lobule is. Remember, in normal liver, you really shouldn't see much in the way of Kupffer cells, lymphocytes, plasma cells, neutrophils. You really shouldn't see many inflammatory cells in the normal liver. Yeah, go ahead.
Are those zones 2 and 3 or zones 1 and 2?
This is, that's a good question. I think for the purposes of this talk, we should consider them zones 2 and 3. I don't see a portal tract in there to say if there's any zone 1. The important thing I want you guys to see is the portal tract is normal and the interface looks pretty normal. Okay, the busyness is out here where the parenchyma is, and we call that lobular injury. Okay, the cells we're seeing out in the lobule, I think the most predominant cell in this picture are these aggregates of these sort of gray cells. These are Kupffer cells, so this is Kupffer cell hyperplasia. They're all revved up. They're chewing on debris from the damaged liver. Some of the debris we can see is right here. That's an acidophil body there. That's an acidophil body there. So these are single dying hepatocytes. The Kupffer cells are revved up, chewing on the debris from these dead and dying cells. And some of the smaller blue cells you can see through here are going to be the lymphocytes. So we've got sort of a moderate lymphohistocytic infiltration of the lobule. Okay, that really typifies the acute hepatitis pattern. Okay, remember, so when I'm talking about acute hepatitis, I'm not meaning neutrophils. In most pathology, when we say acute inflammation, we mean neutrophils. In liver pathology, acute hepatitis means lobular-based injury, not portal-based injury. Okay, so this is your acute hepatitis pattern of injury. Higher power look, you can see that Kupffer cell hyperplasia, and you can really see the acidophil bodies, those red dead hepatocytes. Okay? So, we've got a lobular pattern of injury, zones 1 and 2. Zone 3 is probably also involved in this one. Really no portal inflammation, so it's not a portal-based problem. The bile ducts looked okay, no steatosis. So our differential really here is going to be drug-induced injury. It still could be acute infection with these hepatotropic viruses, right? We're not going to think chronic Hep B or chronic Hep C, but it could be acute Hep B, acute Hep C, acute Hep A, something like that. Other weird zebra infections we should think of, toxoplasmosis, fungal, but we've really ruled out the chronic viral hepatitis. We've ruled out autoimmune because there's no portal-based inflammation. There's no steatosis. Alcohol is usually a steatohepatitis. Okay, there's no fat, so it's probably not alcohol. Okay, this was a complicated patient because most of the serologies that were done were negative. So Hep B, Hep C were negative. The autoimmune markers for autoimmune hepatitis were negative. AMA, we didn't think it was PBC, but the clinicians were sort of desperate. They didn't know what was going on. That was negative also. Tox screen was negative. Nothing really revealed on the imaging. In most patients like this, at this point in the workup, I would say most of the time you'd probably assume it's some kind of drug or toxin or some funny herbal tea the patient drank that causes liver injury. Since none of these specific markers are coming up positive. The pathologist, when he sees this liver injury, I would go look into the note too and see all that stuff is negative and sort of come up with this unsatisfying diagnosis. top line would be acute hepatitis, and I'd have this long explanatory comment about how, based on the pattern of liver injury, I can't actually tell what's causing this. Most cases of acute hepatitis all funnel down into the same histologic pattern, whether it's an acute virus, such as Hep A or Hep B, or even acute Hep C versus drugs versus other infections. They all kind of look the same. So as a pathologist, when we see that acute hepatitis, that lobular pattern, we have a hard time saying exactly what the etiology is. Okay? So that's kind of how I sign these cases out. And I hope nobody calls me. Okay. What we can do, and where I do think pathology can be helpful in some of these cases, is telling the clinicians what the disease is not. So don't spend time worrying about these things. It's definitely not. It still could be this long list of other things, but at least you don't have to worry about these, right? So we can say, at least in this case, it's not autoimmune, it's not a chronic viral hepatitis, and it's not alcohol-mediated injury. Okay, so at least we can help them focus their differential on some of the other things. This case had a very astute clinician who looked back at the medical history and thought, this guy's kind of at risk for Hep C. The serology is negative, but let me get the nucleic acid testing and see if this could be a case of acute Hep C. Right? So in an acute viral hepatitis, the serologies may not have had time to become positive yet, so you have to consider that too. So he did the testing, he found a viral load of over 1 million. So this turned out to be an acute viral hepatitis, acute Hep C. Pretty uncommon. I'm not sure I've seen one since. But really the diagnosis in this case was made on the clinical end, not by the histology. Okay? We talked about that. So this sort of just rams home that point. This is that same case of acute Hep C. Remember I told you a lot of different causes of acute hepatitis funnel down into one histologic pattern. This is an example of acute toxoplasmosis hepatitis. They look the same. Okay? It's very difficult for a pathologist to define etiology when the tissue presentation is an acute lobular hepatitis. Both has this Kupffer cell hyperplasia with acidophil bodies and scattered lymphocytes in the lobule. So just keep that in mind. Most of you won't be pathologists, but if you become clinicians, just keep in mind that if you get acute hepatitis diagnosis from your pathologist, there's really very little a pathologist can do to sort out that differential with the tissue. It's going to be a lot of more clinical ancillary work than what you can do in histology. Okay. Any questions about that? Okay, well, about 4 minutes here, we can move through here. So this is a 41-year-old woman. She had septic shock, markedly elevated LFTs, and another hepatitic pattern, very high, about 1,000. Alk phos was elevated too. She had a very high titer ANA, anti-nuclear antibody. So what story am I telling here? Autoimmune. Yeah, I'm telling you it's autoimmune, aren't I? So we don't even need to see the tissue. No, we need to see the tissue. Okay, Hep B, Hep C is negative, AMA is negative. Okay. So here's her tissue. This is a trichrome stain. I think it shows the pathology better, so I included this instead of the H&E. What I want to point out, this is the central vein here. This is a pleural tract here. The light blue staining on a trichrome means that there's been necrosis. Okay, so the liver cells in all this light blue area have died out, and what you're seeing is collapse of the reticulin framework that helps support those cells. So this is pericentral necrosis or zone 3 necrosis. Okay, the pleural tract doesn't look all that inflamed, looks pretty normal. The clinicians maybe are thinking this is autoimmune. We all did because of the positive ANA. Based on the tissue, do you guys want to call it autoimmune? Sure? Maybe not. What's autoimmune? Remember, what's the pattern of autoimmune? It's portal-based, chronic with interface. Okay? This is pericentral necrosis. Pleural tract looks okay. No chronic, no interface. So this does not, the pattern here does not fit for autoimmune. Okay? It fits for a zone 3 pericentral necrosis type pattern. Remember, those are going to be drugs, shock liver, or ischemic injury, things like that, okay, are going to be mainly your pericentral necrosis-based pattern, okay? Summary of the findings. Now remember, this patient had septic shock, right? So this tissue is very compatible with ischemic liver injury, with quote-unquote shock liver, okay? So the positive ANA in this case was a red herring. This was shocked liver. The patient got supportive treatment, and her liver enzymes improved. It's important because she was septic, you don't really want to give a patient septic steroids if you don't have to. So it was important to look at the biopsy in this case and say, probably not autoimmune, let's go with shock liver. Okay? This is when liver biopsy is probably the most important, or probably gives the most clinical information. When there's a very limited and directed clinical differential diagnosis, that's usually when the pathology can help sort out a more specific pattern. If the clinical differential is extremely broad, the liver biopsy may be shortened a little bit, but it's not going to bring you down to the final answer. In this case, the differential is mainly is autoimmune or is it ischemic liver injury. The biopsy shows ischemic injury, and so we go with that. Okay, we'll make this the last case. Okay, case 5. This is a 45-year-old woman. She presented with jaundice. She had that hepatitic pattern also. Alk-Phos mildly elevated, GGT a little bit elevated. Here's her serologies. They all look normal. Viral serologies were all normal. She had no alcohol use. Really no risky behavior at all. So we don't have a whole lot to go on in this case. Okay, clinical differential. Autoimmune, maybe. Serologies were negative. At this point, I think most people would think it's going to be some type of drug or a toxin or an herb. Remember, it could be acute viral. The presentation isn't that dissimilar from our patient with acute Hep C. Okay, so this is her biopsy. Here's the portal tract. What color is it? It's blue. Okay, he's got a blue portal tract. Okay? Now, what do you guys think about this one? I've shown you some cases of blue portal tract, chronic portal-based inflammatory pattern, where the interface is really well defined. Can you guys really define that interface very well? I can't. I mean, it's hard to say where the portal tract ends and where the liver begins. I guess you could say it could be way out here, but it's very fuzzy. And that's because there's severe interface damage. There's a lot of lymphocytes getting out there and damaging liver cells. Okay? So we've got a chronic portal-based pattern with severe interface damage. What's your diagnosis? Autoimmune, but her ANA was negative.
Yeah, ANA's garbage.
You don't care. No, I like it.
Every time we have ANA, it's always garbage.
Good. Actually, ANA can be a problem, can be a big problem. Another example of the interface activity. Lymphocytes, plasma cells sneaking out, damaging the hepatocytes. Okay. Here's an example of a cluster of plasma cells directly in the parenchyma. Okay. Summary of findings. Main differential. Remember, drugs look like anything, so drug is always in the differential with an ANA negative pattern that looks like autoimmune hepatitis. A pathologist can never exclude a drug. But we really ruled these out. Okay, it's not alcohol, there's no fat, it's portal and interface based, it's not really lobular based. Hep B and Hep C, no, we don't get a severe interface with that. PBC, no, we don't get severe interface with that. And if it's not alcoholic steatohepatitis, it's definitely not NASH. Okay, so here's the problem. Looks like autoimmune, but the ANA is negative. Pathologists can never exclude drug in that setting. In this patient's case, the clinicians did do a great drug history. They couldn't find anything as a possible culprit, so they started steroids for presumed ANA negative autoimmune hepatitis, and her LFTs they got normal very, very quickly. Okay, so after all is said and done, this is a patient with ANA negative autoimmune hepatitis. Okay, diagnosed, made by everybody. Okay, it's not the pathologist, it's not the clinician, it's not the chemist who does the serology. Everybody's kind of got to get together to figure these cases out. Okay? And I want you all to keep that in mind when you're on the wards looking at liver patients. There's really never a single clinical test often that can tell you what the problem is. I guess the exceptions are the typical patient with a positive Hep C serology, but in complicated liver patients, you've got to put the pathology together with the presentation, the patient's drug history, and any of those ancillary tests you can do. You've got to put that all together to get to a definitive diagnosis. Okay, the tissue is usually never the complete answer. Okay, we can skip these pieces up until you guys are itchy. If you want to go through them on your own, go ahead. Let me just bring your attention to the summary slides. So at the end you'll see some summary slides, summary of histology. These just highlight the main points of all these inflammatory patterns of injury. I did not go into alcoholic hepatitis or steatohepatitis. Read through these, look at the pictures. It's a common disease you all should know about. If you have questions, you can email me or come find me. Okay.